This video presentation and its accompanying materials are copyrighted by the American Association for Respiratory Care, AARC. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. As a registered participant, you are authorized to duplicate course materials for this program for each participant viewing at your facility. This presentation and accompanying materials can be used by staff within the institution, but cannot be resold, distributed, or displayed for profit. Copyright 2017, all rights reserved. The following is a presentation of the American Association for Respiratory Care. Welcome to Current Topics in Respiratory Care. Today's topic is Capnography in the Neonatal Pediatric Population. Craig Smallwood is a registered respiratory therapist and research associate in anesthesia at Harvard Medical School and coordinator of clinical respiratory research, Department of Anesthesia, Division of Critical Care Medicine, Respiratory Care at Boston Children's Hospital. This presentation is sponsored in part by an unrestricted educational grant from Philips.
Thank you for being with me today. I have the great pleasure of discussing a really important topic in neonatal and pediatric patients, CO2 monitoring. Specifically, we're going to go over capnography and volumetric capnography in these patients. And before we get started, I have a question for you. That question is, if you only had one physiologic parameter that you were able to measure in your patients, what would you choose? Given the respiratory rate, heart rate, SpO2, blood pressure, etc., I'm going to try to make a strong argument that you could probably choose CO2 and learn a lot about your patients that you otherwise would be missing with a lot of those other physiologic parameters. So our specific objectives today are to, number one, discuss the normal capnogram in both the neonate and pediatric patient. We're going to compare and contrast some differences in the normal patient. Number two, we're going to identify probably the most common abnormal capnograms. I've kind of cherry-picked several that I think are the most important and tell you some different pathophysiologic things about your patients. And next, we're going to estimate, or I'm going to expect you to be able to estimate an expected CO2 elimination value in neonatal and pediatric patients. So CO2, it's a wonderful molecule. Monitoring CO2 can tell you a tremendous amount of information about your patient, which is, I think, a blessing and also a curse. Anything from obstruction of the airway, CPR quality, cardiac output, spontaneous respiratory effort, pulmonary perfusion or changes thereof, artificial airway placement, verifying endotracheal tube placement, quality of CPR as well as return of spontaneous circulation, ventilation titration, as well as nutrition titration. As you can see, this is not a comprehensive list, but there's a lot of things on this slide that I think you can appreciate CO2 monitoring will play an important role in this patient population. Specifically, we're going to touch on a few things. Number one, a technology overview. I think it's going to be important to review the underpinnings, the actual hardware that's going to allow us to measure these things in our patients. We're going to talk about capnography, time-based CO2 monitoring, as well as volumetric capnography, that is volume-based CO2 monitoring. And lastly, we're going to look at a couple of studies that I've selected, not because they're the only ones in the literature, but I think that to me they represent an important step in a couple of areas that are going to be really exciting in this patient population. So technology overview. So CO2 measurement, we got to know how it works. The mechanism of action is spectroscopic, which is a fancy word for light-based. CO2 is a wonderful molecule in that if you shine a specific wavelength of light, the CO2 molecule is going to absorb a specific amount of that. And so we can use that principle to titrate or really measure the concentration in our subjects. You can see in the slide, we have an infrared light-emitting diode that's going to light the system. And then on the other side, we're going to see the sensor. And the CO2 molecules highlighted here, those little black dots, are going to absorb that IR light. So any difference between that which is transmitted on the one side and received or monitored on the other side is going to be proportional to the concentration of CO2 in our patients. You'll see all the time devices available on the market are NDIR, which corresponds to non-dispersive infrared measurement. That is the specific wavelength and the physical properties of the light that we're leveraging to measure CO2. Next, not so much for CO2 time-based monitoring, but when we get into volumetric monitoring, which we will in a few minutes, we have to carefully consider how we're measuring the flow. There's a couple different ways in the literature to do this. Some very popular ones I've kind of highlighted here to you on this slide are a pressure differential pneumatachometer as well as a heated wire anemometer. I'm showing you the depiction of the pressure differential pneumatac, and I think it's probably the most common and probably most robust in terms of actual clinical utility. Perhaps not as accurate as a heated wire. But in general, the principle is that when you pass a gas through a restricted orifice, that's going to be the pressure differential. So when we change from a large diameter to a smaller diameter or vice versa, we can calculate a pressure drop or increase. Typically, these devices will look at a pressure drop. So we're going from a larger diameter to a smaller diameter inside this pneumatac. And the pressure drop that we note is going to be correlated with the volume, or really the flow, which we can then back calculate the volume in our patients. Let's talk about some advantages and disadvantages of side stream and mainstream capnographs. For a side stream device, I think the main advantages are, number one, it's a lightweight airway adapter, which is especially important in neonates and small babies who we worry about excessive weight inadvertently extubating our patient. Number two, it can be readily integrated with the monitor. So for devices where we want to have CO2 monitoring capability at the bedside, especially in emergency departments, this can be an advantage. For a mainstream device, some devices allow you to integrate with your physiologic monitor. There's typically no time delay. That is, there's no delay between the patient actually exhaling and exactly what you're seeing on the monitor, which can be advantageous in some circumstances. And it's typically heated and therefore less prone to error from condensation or secretions basically building up in the airway monitoring window. Some disadvantages of the side stream technology. Number one, since there's no heat, unlike the mainstream technology, condensation can build up and get clogged in the aspirating line and therefore preclude you from measuring CO2 with this device in some cases. There's a time delay because the gas is not going to instantaneously be at the device where you're measuring CO2. So there's a transit time from where the device is monitored or aspirated at the patient's proximal airway to when it actually enters into the device to get measured. And this could be anywhere from a second upwards of 2 seconds, depending on the device and length of the aspirating line. Historically, these devices also have demonstrated to be inferior in terms of accuracy in neonatal populations. Disadvantages, I think, of the mainstream CO2 monitoring device. Number one, it's a bulkier airway adapter, making it more heavy and perhaps less applicable in small neonates. And number two, some of these devices may require more frequent calibration. The other really wonderful thing that's happened probably in the last decade or so has been we've seen a lot of these technologies being integrated into mechanical ventilators, meaning that we don't have to independently own and operate devices that monitor CO2, but the advantages of CO2 monitoring will be, number one, displayed on the ventilator monitor, and in some cases, the calculation of VCO2, that is CO2 elimination, will be automatic as well. I've compiled this table of 5 popular ICU ventilators available in the United States to illustrate some important things that I think you may find helpful if you're in the decision process in terms of buying this equipment or potentially assessing your equipment for accuracy and comparing and contrasting to other technology available on the market. Number one, I think the most important thing is to look at the actual CO2 specifications, that is the time-based performance and the CO2 concentration accuracy of the device. You can see the specification range, that is 0 to whatever the upper limit is of the CO2 monitor for the device, as well as the manufacturer-provided specifications. The next most important column to look at is the CO2 elimination, or the VCO2 accuracy column. You'll see here that only 2 devices out of the 5 provide both a range and a manufacturer-supplied accuracy. While that doesn't necessarily mean that the other devices aren't accurate, it is a little bit concerning that those accuracy values aren't provided, and we have to lean on diligent clinical researchers in our field to tell us how these devices actually perform. But please refer to this table as much as you'd like. So we've completed our technology overview, and we're going to get into some capnography, which I think is going to be a little bit more fun than we've discussed thus far. So capnography. I think this may go without saying, but it's really the graphical display or presentation of the partial pressure of CO2 throughout the breathing cycle. The units often seen in the North American space of the world is millimeters mercury, but you may often sometimes see percentages or even kilopascals or some other measure of pressure. Indications for CO2 monitoring. I think the first thing that you'll appreciate by looking at this slide is the list is actually pretty small. What I've attempted to do is look at the literature and summarize for you what I think are the most strong recommendations over the last couple decades of literature in the neonatal and pediatric population for using CO2 monitoring. Endotracheal tube placement verification. There's a lot of good data in the neonatal and pediatric literature that supports using CO2 monitoring to verify that the endotracheal tube is in the correct place down the respiratory tract. Upon intubation, we want to look for two things. Number one, a really good looking waveform, and we're going to look at that in a couple slides. Number two, we want to see a partial pressure of CO2 that would be much higher than less than 10 millimeters mercury. We have to remember that CO2 may be present in the GI tract and in and of itself is not necessarily reflective of being in the respiratory tract. However, once we start to see partial pressures upwards of 30 or 35 millimeters mercury, we can be fairly confident that we're in the respiratory tract. During transport as well, it's an important tool to be able to make sure that the airway is intact and that our mechanical ventilator or our bag is actually connected to the respiratory system. This can be done both within a hospital and from hospital to hospital. Number two, there's a lot of literature supporting CPR quality assessment using CO2 monitoring. During chest compressions in neonates and peds, primarily pediatric populations, anything less than 10 millimeters mercury is an indication, is a gross indication of inadequate chest compressions. And the vigor with which we're applying those compressions needs to be improved till such time as we see a larger number in our CO2 monitor. Number two, if we see a marked increase in the CO2 concentration as we're doing compressions, it can be associated with return of spontaneous circulation and is an important metric to help us assess whether or not the patients are responding to the treatment. Post-anesthesia. As patients are increasingly taken from the OR to recover in other areas of the hospital or having sedatives or other drugs that may impede respiratory function on the floor, CO2 monitoring is an important tool to maintain or for us to ensure that the patient is maintaining their respiratory system appropriately. In this case, the devices can be applied non-invasively if they're spontaneously breathing or invasively on a mechanical ventilator. And really what we're looking for is a presence of a substantial amount of CO2 and no sudden decreases in that concentration. Pulmonary circulation, it has been shown in some data to detect changes sooner than oximetry and may play an important role. The most important one, and I think is probably the most actual common application of CO2 monitoring, is within the ICU just as a gross surrogate for PaCO2, that is arterial CO2 concentration. It didn't make the list because there's not a ton of data suggesting that this is a very accurate thing to do. However, there is some data suggesting that it's a relevant thing to do when it's applied in the appropriate circumstance and with caution. Speaking of arterial and end tidal CO2 gradients. So the arterial to end tidal CO2 gradient, I think, is an important concept when you're monitoring CO2 in any population. What I've done here is produce this cartoon, really, of a simple illustration of why we see a gradient between the arterial and end tidal CO2 concentrations. We have to remember that every breath that we breathe in, there's a portion of it, and I'm not going to go into the specific fractions at this point in the presentation. There's a portion of our breath that does not actually exchange gas and therefore does not have CO2 in it as we exhale. And hopefully, there's a large proportion, however, that is involved in gas exchange and therefore CO2 is present. The estimated PaCO2 that I've used to illustrate this to you guys is 40 millimeters of mercury. And you can see that depicted in this tank, which has the blue level is basically the alveolar gas, the portion of our breath that was involved in gas exchange, has a partial pressure of 40 millimeters of mercury of CO2. We mix that together, we exhale. What happens is that the gradient between the arterial and what we actually measure in the end tidal CO2 is increased, and the partial pressure of CO2 is going down. An important note is in patients who have varying degrees or increases in the proportion of dead space in their breath, will have a larger increase in that dead space. In healthy patients, this gradient in neonate is expected to be around 0 to 3 millimeters of mercury. That is, if their PaCO2 concentration is approximately 40, we would expect with our end-tidal CO2 to measure somewhere between 37, 38, 39, or 40 millimeters of mercury. In pediatric patients, we see the gradient a little bit increased, anywhere from 2 to 5 millimeters of mercury. So now is when the fun begins. We get to look at some capnographs. Our rough outline, I said I was going to share 5. We're going to look at a normal and then 4 abnormal CO2 tracings. My inspiration for doing so is to pick out those that I think are most clinically different in their underlying pathophysiologic cause, and then also compare and contrast to be able to understand what a normal is and those key aspects of the capnograph to pick out that may clue you into something important happening in your patient. First off, we have a normal pediatric capnogram, very similar to the adults. What I've done here is on the top put a healthy newborn capnogram and on the bottom a healthy child. Number one, we can see that the frequency at which we're seeing the CO2 tracings in a healthy newborn is higher. This is because they have higher CO2 or higher respiratory rates. And number two, there's a couple important differences towards the end of the CO2 tracing. I've broken it up into 4 distinct phases and chosen to mark inspiration, so the patient breathing in, as 0. And as we begin exhalation, we start to count in positive integers. So phase 1 is 1. That is going to be starting the exhaled breath. We're not going to see a whole lot of CO2 in that breath. So basically the concentration that you can see in the healthy child and the newborn at this stage is 0. In phase 2, let's look at the healthy child. We see a marked or sharp increase or rise in the CO2 concentration over time. And this is the mixing phase or the transition phase. What we're going to be monitoring in our patient basically are those conducting airways. And we're starting to get down to the alveolar gas where we see really high concentrations of CO2. Continuing on with the healthy child, we look at phase 3. We see a pretty obvious plateau or almost a flat top to the CO2 tracing. And this is the alveolar gas. This is going to be where the bulk of gas exchange is going to be occurring in your patients. Let's compare that to the healthy newborn. So phases 0, 1, and 2 look perhaps fairly similar. The slope of phase 2 in a healthy newborn may be a little bit different. But once we get to phase 3, what you'll notice is that either 1, the length of phase 3 is very short compared to a pediatric or an adult patient, or 2, it could not exist at all. And you'll see this kind of shark tooth pattern in a newborn. We're going to look at, later on in this presentation, that shark tooth pattern as being an abnormal finding in a pediatric patient, but in a healthy newborn, this is what you'd expect to see and should get familiar and comfortable with assessing these. Obstruction. We're going to look at an obstructive wave forward pattern for you, and this is what we're looking at now. It's perhaps one of the easiest to identify, but also most important. Number one, what we can see is phases 0 and 1 look similar. Inspiration occurs, there's no CO2 in the breath. We start to exhale, there's no CO2 in that portion of the breath yet. But once we get to phase 2, we've noticed some pretty important differences. Number one, there's a very slow rise in the concentration of CO2 in a patient with obstruction. These types of patients may or may not have a phase 3, and typically with moderate or severe obstruction, we will not note a good plateau. It's also noted that in patients with anatomic obstruction of the large airways or conducting airways, the gradient between PaCO2 and end-tidal CO2 is going to be larger in a patient if you notice this type of waveform pattern. I should also note that this pattern does not necessarily mean asthma or bronchiolitis or some other obstructive process within the respiratory system. It could be as simple as a mechanical obstruction of the endotracheal tube, whether it be pinched or clogged with mucus, or it could be a misplaced endotracheal tube that is perhaps gone a little bit too low and is sitting right above the carina, and therefore the tip of the endotracheal tube is obstructed by the patient's actual anatomy. Let's look at identifying rebreathing in the capnogram. Some important things to learn about identifying rebreathing in your patients is, number one, the actual shape of the capnogram looks very similar to a normal patient. You can note here on the top that phases 0, 1, 2, and 3 all have a fairly similar actual presentation in terms of shape and rise in CO2 concentration, as does our normal patient. What you should be able to note is that during inspiration, that is when the patient is inhaling past the CO2 monitor, the concentration of CO2 may be elevated. In a normal circumstance, we do not want to have that patient breathing in CO2 as it's going to impede proper ventilation and indicates a problem that needs to be corrected. Here you can see that there's no increase or decrease in that the level between breaths, but what you may see in clinic is a slow rise or a staircase as CO2 builds up in the system. That is, every time the patient exhales and tries to breathe in, there's even a little bit more CO2 in that system. This is perhaps one of the most important ones to recognize at the bedside, but also one of the most difficult to correctly assess. On the bottom for reference, again, is our normal capnogram. On the top, we see a patient, and the shape, again, in general, is similar to the normal capnogram. However, you'll note these slight decreases in CO2 concentration throughout primarily phase 3 of the capnogram. What this can indicate is a transient or small inspiration by your patient. This can be due to asynchrony or inappropriately set ventilator settings, namely trigger sensitivity. Or it could be a product of discontinuing a neuromuscular blockade, in which case the patient is attempting to take a spontaneous effort, but unable to do so completely and fully. Cardiac oscillations. This is probably my favorite CO2 abnormal tracing. You can note here that in phases 0, 1, 2, and the beginning of 3 all look fairly normal. Towards the end of phase 3, as the patient concludes expiration and begins to transition over into inspiration, what we note is a decaying oscillatory pattern in the CO2 tracing. What can be important to diagnose this at the bedside is to look at that periodic oscillation in the capnograph and correspond that rate to the patient's heart rate. It's probably my favorite because it's really not that big of a deal most of the time. Most patients who you'll notice this in are cardiac patients in which their intrathoracic heart is able to cause flow oscillations and therefore disturb the CO2 pattern. You may also notice it in patients who have excessively long expiratory times, during which the actual expiratory flow is fairly low, meaning that the heart is able to oscillate and generate some flow within the circuit. So we've looked at technology, we've looked at my 4 favorite abnormal capnograms, and now we're going to get into carbon dioxide elimination and volumetric capnography. Before we move on, I'd like to tell you my real philosophy with monitoring CO2 and identifying abnormal capnographs in your patients. Number one, in very few circumstances can CO2 monitoring tell you definitively whether or not there is a specific pathophysiologic process going on in your patient. Rather, it's corroborative. That is, it can support or perhaps generate hypotheses which can be corroborated by looking to other variables in our patients in specific disease processes. The second thing is that I've only shown you 4 abnormal CO2 tracings, and there is essentially a limitless book that could be written on abnormal CO2 tracings observed in the bedside. However, I think it's important to most clearly understand normal findings in both neonates and peds, such that it'll be easier for you to clearly note, number one, the phase at which that's noted, and the actual change in the CO2 tracing to be able to try to figure out at the bedside what's happening with your patient. Feel free to look at all kinds of excellent resources online, as well as on aarc.org. All right, we've done some technology. We've looked at how we actually measure CO2 and flow. We've looked at a handful of different CO2 tracings and how to identify and what's important about that. Next, we're going to get into carbon dioxide elimination and volumetric capnography. So VCO2, which is essentially short for carbon dioxide elimination, is the volume of CO2 gas exhaled per unit time. The units are typically displayed, depending on the manufacturer, either in mLs per minute, mLs per gig per minute, or perhaps liters per minute. Volumetric capnography, on the other hand, is a plot, or really a graph, of the CO2 concentration versus exhaled time. This is different than CO2 time, which is obviously looking at the horizontal axis being time instead of volume. There's a lot of important things we can glean, and we'll get into that. Indications for VCO2 monitoring and or volumetric capnography. Number one, it can be a surrogate for detecting changes in pulmonary circulation, and it can do this in some cases sooner than oximetry. It can also be used to titrate specific therapies or specific variables on your mechanical ventilator. One such example is PEEP. It can also be used to identify whether or not the patient has a positive or a negative response to an intervention at the bedside. Although there's not a whole lot of literature for this indication, I'm going to get into applying that in a few minutes. And number three, this is perhaps the best studied, was really using dead space assessment to detect disease severity, extubation readiness, and also mortality risk. And I'll give you a couple examples in the literature of those applications. So let's talk about dead space assessment. Dead space to tidal volume ratio predicts successful extubation in infants and children. This is some work that was done in a population of mechanically ventilated pediatric subjects. And what we see here on the left is, on the top left is phase 1, 2, and 3. You'll notice that on the y-axis is the expired CO2 concentration. I think it's easiest to think of this as a percentage. And then on the x-axis, or the horizontal axis, we see the expired volume. There's a couple of important things that we can do with Euclidean geometry. Number one, if we now look at the bottom graph on the left here, we see X, Y, and Z being these three distinct areas of the volumetric capnograph. Area X corresponds to the alveolar tidal volume. Area Y is the physiologic dead space. And Z, or Z for my Canadian friends, is the anatomic dead space. And these things can be calculated if you also have a PaCO2 value collected in that patient. I think it's important to note that many of these devices will be able to calculate the alveolar tidal volume or estimate the alveolar tidal volume dynamically from breath to breath, and that can be a useful metric when titrating ventilation in your subjects. On the right-hand side, we have VD to VT, that is the ratio of volume to tidal volume, or that is the ratio of dead space volume to tidal volume. The calculation here, I'm showing you the Enghoff modification of the Bohr equation, is PaCO2, that is arterial CO2 concentration, minus PeCO2, which is the volume average CO2 concentration, divided by the arterial CO2 concentration. Doing so gives you a number between 0 and 1 that is the fraction of dead space in your patient. So back to the study. This was a study that was done in the year 2000 in 45 mechanically ventilated pediatric subjects. And what the authors sought to provide was a mechanism by which we could assess our patients before extubation and assess their risk of reintubation or failed extubation. On the horizontal axis, we see these binned areas in increments of 0.1 for VD to VT. So the lowest VD to VT is on the left side, and in a graded fashion, we get up to a 0.9 to 0.1 range on the far right. On the y-axis, we see a percentage. This is the percentage of patients who required reintubation. And what we note is that the patient has an increase, or what they observed in their population was that as the VD to VT increased in their population, so too did the proportion of subjects who failed extubation and required reintubation. I think there's a couple important things we can take away from this. Number one, the higher your VD to VT, probably the worse you're going to do upon extubation. The sicker you are is really what that's telling us. Number two, there's also a fair amount of uncertainty at specific binned areas, and the authors discuss this in their paper, as to what's going to happen at specific VD to VT ranges. For example, if we looked at the range of 0.5 to 0.65, or somewhere in there, we can note that although the incidence of extubation failure is much higher than those areas, or those ranges less than 0.5 to 0.65, there's still 45 to 50% of those patients did just fine upon extubation. This certainly isn't a limitation of using this method as a sole indicator of extubation success. However, it's an important step in using this information, and could probably provide you some important information as part of a package assessment to assess whether or not your patient is going to respond well to the extubation. Some important areas that I'm not going to discuss in length are assessing disease severity. This has been done in both neonates and pediatric subjects. In specific patient populations, congenital diaphragmatic hernia, for instance, specific thresholds for VD to VT have been associated with a reduced mortality and reduced need for ECMO. And I think this in general represents a fruitful area of research that continues to go on this day with VT. Let's talk about carbon dioxide elimination. That is the actual numeric value of excreting CO2 per unit time in your patients. This figure is meant to illustrate the three distinct areas that I think are most important to assess in your patient or think about in your patient to assess CO2 elimination accurately and most relevantly. Number one, production on the far left. We're aerobic beings and we burn energy, and as a product of aerobic metabolism, we consume oxygen and excrete CO2. That's where the CO2 is coming from. The little red knob I've used here is to illustrate basically the rate at which your metabolism can be increased or decreased depending on your specific physiologic state. The middle area is the concentration of CO2. This is what we can measure as a surrogate. We can use end-tidal CO2 to estimate PaCO2, but really the PaCO2 is the absolute concentration in our blood. And then last on the far right, we have elimination. So the VCO2, the CO2 elimination is what we're most focused with here, is really just the elimination. And that's an important distinction when we interpret these things because there can be discrepancies between production and elimination in patients that we monitor at the bedside. Why does this happen? Number one, CO2 can diffuse rapidly in a lot of tissues, so therefore our production of CO2 doesn't necessarily mean that all that CO2 is going to be dumped into the alveolar or into the blood and excreted through the respiratory system, but can be stored in muscle, tissue, basically all throughout the body. However, if you do have a good period where you don't really notice too many discrepancies or increases or decreases in CO2 elimination, there are some statistical methods that you can do to ensure that your measure of CO2 elimination is closest or probably closest to the CO2 production, which is really what we're trying to measure in many cases. So what is a normal VCO2? A normal CO2 elimination in infants and pediatrics. My group at Boston Children's Hospital, we published in 2015 in the Respiratory Care journal a study assessing just this. What we did was we took several dozen patients admitted to our ICU during mechanical ventilation, and we applied an indirect calometer, essentially a device that measures not only VCO2 but also oxygen consumption. This device is very accurate, albeit a little bit cumbersome and not especially practical for continuous measurement at the bedside. We measured VCO2 across a range of patients, and what we concluded was that when you normalize the patient's VCO2 mLs per minute and divided it by their body weight, what we note is that the smaller patients, the younger patients, excrete proportionally more VCO2 than do their older counterparts. Essentially, the younger patients have higher VCO2 when you look at per unit body weight. You can see that illustrated here with the solid line. I'll show you the equation in a second, but before I do, the other important thing to note looking at this figure is the tremendous heterogeneity when we look at similarly aged and heighted patients in our ICU. That is, if you just took one patient at one height, you would be able to get a good estimate of the population, but the individual may be a fair amount high or lower than that estimate. However, it's still relevant and important, I think, to understand what these expected values are to glean the maximum amount of clinical utility from this measurement. This is our equation. So the estimated VCO2, at least in our population, was 115 times height to the power of 0.-7. And although that would work for many people, perhaps it's not the most practical thing to remember, we also looked at looking at VCO2 levels, that is mLs per minute per kilo, by the patient's age. And really my motivation for doing this was to make as simple a tool as possible for us RTs and physicians to be able to look at the VCO2 level at the bedside and immediately know whether or not that was dramatically higher or lower than expected, which could lead to some interesting hypotheses or potentially treatment modalities in our patients. So let's look at these ranges. I blew it up here to make it even more clear, but in patients who are less than a half a year old, so 6 months or less, the mean that we noted was 7.5 mLs per minute per kilo, and our range, and here I'm using a 95% confidence interval, was 6 to 9. In pediatric subjects, half a year to 8 years old, we see the range being narrowed, but it's still around 5 to 6. And then once you get over 8 years old until you're 18 or 20 years old, the range is 3 to 4 mLs per minute per kilo. What you'll notice in some older adults is that that range can go down even a little bit further, and perhaps a value in a gentleman like me would be 2, 2.5, up to perhaps 3 mLs per minute per kilo. So I have a case for you. This is a real case from our ICU, and I'm going to use that as an illustration for the next portion of the discussion. This patient was approximately 2 months old, weighed 2.1 kilos, and had transposition of the great arteries, admitted to our cardiac intensive care unit. He had single right ventricle physiology and pulmonary vein stenosis, and was on a spontaneous mode of mechanical ventilation. Pressure support ventilation, 12 over 4 centimeters of water, PEEP, with an FiO2 of 21%. Our monitored values are this. The tidal volumes were fairly high, 8 to 11 mLs per kilo. Respiratory rate also fairly high for this patient, but not too excessively high, 40s to 50s. However, the clinicians had noted that the end-tidal CO2 had been rising, and our observed VCO2 values were 31 to 46 mLs per minute. Our venous blood gas noted a modest acidosis. And the thing that sticks out to us, and what I'd like to illustrate, is the VCO2 number. This patient was presented with having a fairly stable respiratory pattern, albeit a complicated surgical cardiac case. The team wanted to extubate, wanted to get this patient out of the unit, wanted to get this patient home. However, they were unable to do so, unable to really wean below the settings that they were on. So why is that? Well, given that this is a VCO2 discussion as part of our look into CO2 monitoring, the answer is probably the VCO2, and that's exactly what it was. CHO, the carbohydrate load that this patient had been eating or really being delivered in the ICU was excessively high. So what the clinical team did was look at the actual VCO2 level. So 31, I'll just divide that in half, so 15 mLs per kilo. Remember, we're expecting this patient probably to be around 7.5 mLs per minute per kilo, so double what we'd expect. So that's a red flag. And why did that happen? Because they're on too much carbohydrates, which if you eat more food, obviously you're going to be combusting that food and then putting a CO2 burden on this patient as they try to break that down and produce more CO2. So we cranked down the carbohydrates, and this is what we had. A much more reasonable clinical presentation. The patient's VCO2 decreased, which is what we hoped to accomplish, able to get them on lower respiratory rates, more reasonable tidal volumes, and started to ventilate even a little bit better. This patient was extubated and went on to do quite well. So we've kind of transitioned now into a little bit of nutrition, looking at VCO2, and I think this is particularly an interesting area as we spend a lot of time with multidisciplinary teams in our ICUs throughout the country. Here, I'm illustrating to you a couple of ways by which gas exchange is used to calculate energy expenditure in neonatal, pediatric, and even adult subjects. The Weir equation, which was published in the middle of the 20th century, basically gave to us an equation by which if you measured oxygen consumption and CO2 elimination, as well as the urinary nitrogen production, which is a byproduct of protein catabolism, you can calculate the energy expenditure in your subject. What's really wonderful is we don't have to worry about urine collection. The modified Weir equation essentially drops off that term because it doesn't contribute a great amount of actual accuracy. I think it's around 2 to 4%. So if we forget that and just do the gas exchange monitoring, we can get some important information about how much energy our patients are burning. And our nutrition researchers and dietitians are particularly invested in accurately delivering or prescribing that nutrient that the patient needs. So this is from a colleague of mine, Dr. Mehta, who looked at a cohort of mechanically ventilated subjects in our pediatric ICU at Boston Children's. What he noted was that there is a discrepancy because the nutrition team essentially doesn't have good tools to accurately assess energy expenditure. There's a discrepancy between what is estimated, that is some equation that these folks lean on, which is really based on demographics, that is age, height, weight, sex, and try to estimate the amount of energy based on those things. It's just really not that accurate. What he noted was that in many subjects, we're going to look here on the left is a Blondal-Altman plot of the agreement between the estimated, that is the demographic-based equation, which we know is really not that accurate, and they measured a value. So on the horizontal axis, the x-axis, we see a mean of those two calculations, and on the horizontal axis, we see a difference between those methods. And in an ideal scenario, what we'd love to see is all these dots that we're looking at be exactly lined up on a zero bias line. What we note is that individual subjects have a varying range of agreement with the actual estimates. In some cases, in a handful of cases, it was just adequate. However, in a lot of cases, it wasn't. But it wasn't a repeatable or predictable bias either above or below, meaning the individual agreement was quite poor. And on the right, what the team did was extrapolate the estimated energy excess or deficit that would be noted over a period of time in the ICU. And this is really meant to illustrate what can happen when you lean on these inaccurate methods and compound them over several days in the ICU. So clearly we need a method to individualize this measurement. We're going to look at a really interesting study. It's in adults. We just don't have good pediatric data to illustrate this point. This is in a handful. You can see there's not too many patients here. This is in a handful of adult COPD patients. And what the researchers sought to demonstrate was that increases in carbohydrate prescription increase your VCO2. And on the x-axis, we see that expressed as a percentage. That had a negative effect on the physical performance of these subjects. So what we see as the increase, as we see an increase in VCO2 from baseline on the x-axis, there was a corresponding decrease in the performance of these patients by a 5-minute walk test. Clearly, if you overfeed, it may impede your function. In this case, walking. In the case that I showed you a few slides ago, they're not able to actually wean from the ventilator. It's an important issue. So what can we as RTs looking at VCO2s all day do about this? Number one, we can use VCO2 as a surrogate to forget about measuring oxygen consumption, make some assumptions about the Weir equation, and estimate energy from VCO2 alone. This is a tremendous opportunity for RTs to look at measurements on their mechanical ventilators and provide multidisciplinary teams, nutrition teams with information that they may be ignoring. So the equation here is the modified resting energy expenditure from our study is 5.5 times VCO2 times the number of minutes in a day, 1,440. Just to briefly illustrate the agreement, we looked at several dozen patients in our ICU. We compared our method to the standard indirect calorimetry method, which utilizes oxygen consumption using the modified Weir equation. And what we demonstrated was that the agreement, the overall bias was near zero, and the agreement was plus minus about 10 to 12%. Very, very good. That's panel A. And in panel C, we can see the estimated energy expenditure, that is those equations based on demographics, was just not very good. So VCO2 tells you a lot, probably a reasonable amount of accuracy, tells you a lot about how much energy your patients are burning. So before we get to the last piece of the presentation, I just want to illustrate some important bedside tools to be able to apply VCO2 trending in trying to titrate mechanical ventilation in your subjects. In this, you can see that we're going to be looking at VCO2 as a trend over time in the top and PEEP on the bottom. What we're going to do is incrementally increase our PEEP. We're going to do a PEEP titration study, and we're going to, at the same time, measure our VCO2. What we're noting here is that increases in PEEP are going to correspond to either no changes or perhaps increases or decreases in VCO2. The physiologic rationale for doing this is that collapsed alveoli, that is areas of atelectasis in the lungs in these patients, are not going to be involved in gas exchange. And therefore, if we improve VCO2, we can make an assumption that if nothing else changes, if we keep all the settings in the ventilator, the volume, the respiratory rate, et cetera, and our patient isn't breathing, we can assume that increases in VCO2 correspond to alleviation or recruitment of those atelectatic areas. Conversely, if we over-distend our patient, if we increase the alveolar diameter such to the point where we impede pulmonary blood flow, we'll assume that we see a decrease in VCO2. So really what we're looking for is the optimal range at which we see VCO2 in this patient, and that would be this, this made-up PEEP range right here. So we can see up until that point we're seeing increases in VCO2 where we posit that we're alleviating some atelectasis, and after that PEEP, we're perhaps overdistending and losing some pulmonary gas exchange, and therefore seeing a decrease in VCO2. Important disclaimer, although the physiologic rationale for doing so, this procedure looking at VCO2 I think is sound, there's essentially no data to support its use. So I urge you to use this as caution when applying these techniques at your bedside, and if you have the capacity to, please study it. Next, let's look at an intervention. So now instead of trying to titrate a specific parameter on the ventilator, what we want to do is just assess whether or not it was a positive or a negative response to some intervening therapy. The example that I'm going to use is perhaps inhaled nitric oxide in patients in which are off-label, who perhaps require us to increase, or we suspect that pulmonary vasoconstriction is occurring, and alleviating that could improve the ventilation and oxygenation in our patients. So we look at our trend. We're going to put nitric oxide on, or some other intervention in this case, and we're going to look and see what happens. So what is going to happen? Well, I made this illustration up, but this patient didn't respond. We saw no difference in VCO2. And by the way, in this case, we're using VCO2 as a surrogate for changes in pulmonary circulation. An important thing to do with any of these procedures is to ensure that everything can stay as similar as possible before and after the intervention to preclude confounding changes from inaccurately increasing or decreasing your VCO2. That'll enable you to get the clearest snapshot of what's happening to your patient. In some patients, we may see an increase in VCO2, perhaps a decrease. Again, not a whole lot of data support this stuff in the literature, but if you can buy into the physiology fairly sound, then it could be perhaps recommended in some instances, but please study it. Well, we're about to wrap up. I'm going to look at some future directions. I think as a researcher, I think this is perhaps the most exciting part, and I'm only going to spend a couple minutes outlining these couple of studies to you. But what I'd like to do is look at basically two studies that I've kind of cherry-picked, not necessarily representing the bulk of research that's occurring with CO2 monitoring, both capnography and volumetric capnography, but I think are important to highlight different areas of research that we'll see in the neonatal and pediatric population as we move forward. So, computer-aided assessment is an area of rich research. This study, New Prognostic Index to detect severity of asthma automatically using signal processing techniques of the time-based capnogram. These authors sought to, in an asthmatic population, take a signal processing approach by which they automatically extracted features of the capnograph to estimate the disease severity in clinically validated scoring in a population of asthmatic patients. Here we can see on the top a normal capnogram. This is an example from their publication. And on the bottom, the shark tooth looks like an obstruction that we went over earlier in the capnography section of our lecture. While I'm not going to go into all the specific details, I will outline the basic process by which these researchers extracted features and built a model to predict severity of asthma in these patients. Number one, they took features. Features could be anything from the slope, the concentration, the angle of transition at different areas of the capnogram. They took a big long list of those features and then looked at selecting the most relevant ones in this population. They then developed a model and then sought to demonstrate the performance of that model against a validated clinical score. Here are the results, and I'm not going to go over all of it, but in the top table, we see TP percent, which is the true positive rate expressed as a percentage, as a row, and also in the columns, we see from very low to low, mild, severe, and very severe, the clinically validated asthma severity score. And what we see is that for very low severity, the system, the model that they predicted, or the model by which they predicted asthma severity by just looking at the capnogram, was fairly accurate. Clearly, the accuracy kind of goes down as the severity increases. However, compared to some other methods, now if you look at table 2, on the far right is the current method by which the authors are detecting changes and estimating asthma severity in the capnogram. It performed better than some historical benchmarks that they compared against. I think in general, this represents a rich part of neonatal and pediatric research, especially pertaining to CO2, as we see increased amounts of data connected to the bedside, making projects like this very feasible and extremely fruitful. And last, we would all love to have a non-invasive, continuous dynamic assessment or estimate of PaCO2 in our patients. Many of our protocols and our practices call for specific PaCO2 levels that in some cases we'd like to keep very, very tight for some important physiologic reasons. This study was published in Respiratory Care in 2014. The authors sought to develop an algorithm to predict PaCO2 and pH using non-invasive parameters in children with hypoxic respiratory failure. There was 357 children from a 6-year prospective trial data set, and then they went back and applied a couple of different models to estimate PaCO2 using non-invasive end-tidal CO2 monitoring as well as some other clinical variables. So let's check out some results. On the left panel, we're looking at a scatter plot. On the x-axis is the observed PaCO2, the arterial concentration of CO2, versus on the y-axis, the predicted PaCO2 from the author's model. A perfect predictor in this case would have every one of those little blue circles lining up on that 45-degree black line. Unfortunately, and is a reality in many cases, that's not what the authors found. However, if we look at their specific results, we can find some bin ranges, and the authors provide us with a prediction interval, or the percentage of the population that fell within a specific range for 95% of the population and also 80% of the population. For patients who had a PaCO2 less than 35 millimeters of mercury, we can look at their MGP model, which was the best performing model. The 80% prediction interval was plus minus 3 millimeters of mercury. 95% was plus minus 4, not too bad. For 35 to 60, the ranges increased, plus minus 5, plus minus 10. And for greater than 60, the range increased even more, plus minus 8 or plus minus 15. So clearly, in those patients, especially with PaCO2 concentrations greater than 35, this model did not probably perform clinically in a manner that would make it clinically relevant or applicable. However, I think I commend the authors for doing this work and look forward to much more work in a similar process to improve these types of models, come up with different models to get non-invasive and dynamic estimates of PaCO2 at the bedside using end-tidal and other variables. I'd also love to see if manufacturers do onboard VCO2 calculations divided per body weight, just like we see tidal volumes. That would help us out tremendously in neonatal and pediatric populations that have a heterogeneous patient population, as well as integrated energy or nutrition assessment tools. There are some ventilators that offer this, but I think a lot of ventilators could lean on the methodology of just using VCO2 to make that a function at the bedside, and perhaps even some better research to assess response to specific clinical interventions like inhaled nitric oxide, bronchodilators, other pharmacologic interventions, as well as titrating different variables on our mechanical ventilator. So we've covered a lot of ground. I hope you enjoyed the discussion. And as a reminder, we all are experts on technology. We know how CO2 and flow measurements are made in most ventilators and devices. Hopefully you can take those 4 abnormal capnographs, go to your units and find those things right now. The biggest thing I want to emphasize this again is just knowing and understanding what normal is in your specific patient. And we also talked about carbon dioxide elimination, as well as volumetric capnography, dead space monitoring, and some clinical utility and the future directions. That concludes the lecture, and I thank you very much for your time.